Cellulitis is an acute bacterial infection of the dermis and subcutaneous tissue. The infected area is characterized by pain, warmth, swelling, and erythema. Blisters and bullae may form. Fever, malaise, nausea, and rigors may accompany or precede the skin changes. Cellulitis most commonly affects the lower limbs, but other areas, such as the upper limbs, face, ears, and trunk, can also be affected. Cellulitis and erysipelas are commonly seen as manifestations of the same condition, and the terms are often used interchangeably. Cellulitis, this is infection of the dermis and subcutaneous tissue. The infection has poorly demarcated borders. Erysipelas, this is essentially a superficial form of cellulitis, involving the dermis and upper subcutaneous tissues. It can be very difficult to distinguish cellulitis from erysipelas clinically. In erysipelas, borders of infection are sharply demarcated. Appearance is that of a fiery red rash that can be painful. Erysipelas is also known as St. Anthony's fire. This name comes from the Egyptian healer of the Middle Ages who was said to have been able to cure it. If cellulitis is diagnosed, categorize the severity using the Aeron classification system to help guide management decisions. Class 1. There are no signs of systemic toxicity, and the person has no uncontrolled comorbidities. Class 2. The person is either systemically unwell or systemically well, but with a comorbidity, for example, peripheral arterial disease, chronic venous insufficiency, or morbid obesity, which may complicate or delay resolution of infection. Class 3. The person has significant systemic upset, such as acute confusion, tachycardia, tachypnea, hypotension, or unstable comorbidities that may interfere with a response to treatment, or a limb-threatening infection due to vascular compromise. Class 4. The person has sepsis or a severe life-threatening infection, such as necrotizing fasciitis. Causes. Cellulitis develops when microorganisms gain entry to the dermal and subcutaneous tissues via disruptions in the cutaneous barrier. The most common causative organisms are Streptococcus pyogenes, Aphylococcus aureus. Less common causative organisms include Pseudomonas aeruginosa, following exposure to contaminated hot tubs, sponges, or nail puncture. Vibrio vulnificus, following saltwater exposure. Aeromonas hydrophila, following freshwater exposure. Erysipelathrix rhiziopathiae, in butchers, vets, or fish handlers. Mycobacterium marinum, in aquarium keepers. Pastorella multocida and Capnocytophaga canemorsis, following cat or dog bites. Eichinella corrodens, following human bite or fist injuries. Streptobacillus monoiliformis, following rat bite. Streptococcus pneumoniae, Haemophilus influenzae, gram-negative bacilli, and anaerobes, following injury, burns, and other coexisting diseases. For example, people who are immunocompromised have diabetes, TES, cancer, or risk factors. Most cases of cellulitis arise from bacterial infection through a break in the skin, for example from trauma, due to a bite, burn, or laceration, leg ulceration, maceration or fungal infection between the toes, or a concomitant skin disorder, such as atopic eczema. Other risk factors for cellulitis include lymphedema, legoedema, venous insufficiency and history of venous surgery, obesity, pregnancy. Risk factors for either rapid progression of cellulitis or delayed response to treatment include conditions that predispose to infection, including diabetes mellitus, chronic liver or renal disease, immunocompromise, and neutropenia. Chickenpox, varicella, alcohol misuse, neuropathy. Increasing age. Previous cellulitis. Due to persistence of other risk factors such as lymphedema or residual lymphatic dysfunction caused by inflammation with each acute episode of cellulitis. Conditions that commonly result in chronic lymphedema such as saphenous venectomy for coronary artery bypass grafting, pelvic surgery or irradiation, lymphadenectomy or node dissection, mastectomy. Acute complications of cellulitis include deep-seated infection, such as necrotizing fasciitis, a destructive and rapidly progressive soft tissue infection that involves the deep subcutaneous tissues and fascia and occasionally muscles, which is characterized by extensive necrosis and gangrene of the skin and underlying same ruptures. Myositis, inflammation of muscle due to infection. Sepsis, which can be fatal. Subcutaneous B sepsis, post-streptococcal. Chronic complications of cellulitis include persistent leg ulceration. Lymphedema. Cellulitis causes lymphatic inflammation leading to permanent damage. Recurrent cellulitis. Prognosis. Most episodes of cellulitis resolve with treatment, and major complications are absent. However, recurrence is common, and each episode increases the likelihood of subsequent recurrence as well as the length of hospitalization. Take a history. Ask about symptoms experienced, including duration and severity. Recent trauma to the skin, for example, a bite, burn, or laceration. Underlying comorbidities, such as diabetes mellitus, that predispose to infection. Predisposing conditions or environmental conditions which may increase the likelihood of specific pathogens, such as salt or fresh water exposure. Examine the person. Cellulitis is more commonly seen in the lower limbs and usually affects one limb. Bilateral leg cellulitis is very rare. Typical features include an acute onset of red, painful, hot, swollen, and tender skin that spreads rapidly, fever, malaise, nausea, shivering, and rigors. These may accompany or even precede skin changes. On examination, there is usually an obvious skin break where the infecting organism may have entered, such as a wound, macerated skin, fungal skin infection, an ulcer, or a concomitant skin disorder, such as atopic eczema. There may be diffuse redness or a well-demarcated edge that can be marked with the pen in order to monitor progress. Blisters and bullae may be seen. Occasionally, there may be inflamed regional lymph nodes or associated lymphangitis, characterized by the presence of red, linear streaks spreading proximally from the area of cellulitis. If swelling is significant, the skin surface may develop a pud-orange appearance. Severe cellulitis can lead to ulceration and more deep-seated tissue damage. Assess for underlying risk factors, such as lymphedema and legoedema. Exclude differential diagnoses, such as erysipelas, contact allergic dermatitis, deep vein thrombosis, and cutaneous abscess. Investigations. Investigations are not usually necessary but may be considered in certain cases and/or performed in secondary care settings. For example, a swab for culture. If there is an open wound, penetrating injury, drainage, or an obvious portal for microbial entry, exposure to waterborne organisms, an infection acquired outside the UK, or in severe cellulitis. Be aware that swab cultures, especially those of chronic wounds or ulcers, are commonly polymicrobial or colonized with multi-drug-resistant pathogens that are not involved in the etiology of underlying cellulitis. Ultrasonography. For distinguishing non-purulent cellulitis from cellulitis with underlying abscess, and for identifying drainable fluid collection, particularly if the clinical assessment is indeterminate. A skin biopsy, if there is doubt about the diagnosis, and to help identify any unusual pathogens in people who are unresponsive to initial treatment. White blood cell count, erythrocyte sedimentation rate, and C-reactive protein, to detect acute inflammation. Although nonspecific, most people with cellulitis will have elevations in white blood cell count, ESR, and CRP levels. Normal results make a diagnosis of cellulitis less likely. Other relevant tests. To exclude differential diagnoses, such as deep vein thrombosis, septic arthritis, and acute gout. Differential diagnosis. Common conditions that present with unilateral redness and/or swelling include deep venous thrombosis, characterized by pain and swelling of the calves without significant erythema. Septic arthritis, Involvement of the joint and disproportionate pain with joint movement. Acute gout, swelling, redness, warmth, and pain on passive movement. The skin around the joint may be inflamed. Ruptured Baker's cyst may cause unilateral calf swelling. Thrombophlebitis, venous inflammation with thrombus formation, may cause redness, inflammation, and pain. Cutaneous abscess, a hot, red, swollen, and painful swelling, which may need incision and drainage. Erysipelas, a form of cellulitis involving more superficial dermal structures distinguished clinically by raised and well-demarcated borders. Chronic conditions, these are usually bilateral, but if worse on one side, it may be difficult to exclude superimposed cellulitis. Varicose eczema through venous insufficiency, crusting, scaling, and itching. Contact allergic dermatitis can present acutely as erythematous, sore and tender areas of skin, sometimes with blisters. Lipodermatosclerosis, a painful, red, tender, warm, hard, and sometimes scaly rash that occurs in the absence of significant systemic upset. It is most likely to occur in the lower leg in obese women with venous insufficiency. Cutaneous small vessel vasculitis, palpable purpura typically on the lower legs and ankles. Lymphedema, swelling, especially in the subcutaneous tissues, that occurs as a result of excess accumulation of lymph due to inadequate drainage. Oedema with blisters. Panniculitis, inflammation of subcutaneous adipose tissue. Other conditions include drug reaction, characterized by itching and burning. There is usually a well-demarcated area of involvement and a history of similar reaction with prior exposure to the same drug. Necrotizing fasciitis, a destructive and rapidly progressive soft tissue infection that involves the deep subcutaneous tissues, fascia, and occasionally muscles. The presenting signs are usually nonspecific, redness, swelling, and pyrexia. The person is usually systemically very unwell and has disproportionate pain. Metastatic cancer carcinoma erysipelas, a fixed, red patch often with a raised edge and oedema due to lymphatic obstruction. A metastasis from breast cancer is the most common cause, but rarely it may be caused by lung, ovarian, colonic, or pancreatic metastases, or malignant melanoma. Wet gangrene, ischemia of tissue with adjacent cellulitis due to putrefaction of dead tissue. Erythema nodosum, painful, red, warm nodules and plaques on the shins, knees, and ankles. Pyoderma gangrenosum, small, tender pustules or papules that ulcerate with a purple undermined edge and surrounding redness, typically on the trunk or legs. Eosinophilic cellulitis, Wells syndrome, presents with large, indurated erythematous plaques and less commonly nodules that evolve over several weeks. Most people have a blood eosinophilia. Eosinophilic fasciitis. The acute inflammatory stage consists of pain, swelling, and tenderness of the distal limbs. These findings are later replaced by induration, and eventually fibrosis with limitation of the movement of the hands and feet. The affected skin is taut and firmly adherent to underlying tissue with dimpling and a pood-orange appearance. The condition has a symmetrical distribution, and there is a blood eosinophilia in 70% of cases. Management of cellulitis. Arrange urgent hospital admission if the person has class 4 cellulitis, sepsis, or severe life-threatening infection, such as necrotizing fasciitis. Has class 3 cellulitis significant systemic upset, such as acute confusion, tachycardia, tachypnoea, hypotension, or unstable comorbidities, or a limb-threatening infection due to vascular compromise. Has severe or rapidly deteriorating cellulitis, for example, extensive areas of skin. Is very young, under 1 year of age, or frail. Is immunocompromised. Has significant lymphedema. Has facial cellulitis, unless very mild. Has suspected orbital or periorbital cellulitis. Admit to ophthalmology. Has class 2 cellulitis, systemically unwell or systemically well but with the comorbidity. Admission may not be necessary if the facilities and expertise are available in the community to give intravenous antibiotics and monitor. Person, check local guidelines. has symptoms or signs suggesting a more serious illness or condition, such as osteomyelitis or septic arthritis, consider referring people to hospital or seek specialist advice if they are severely unwell. Have infection near the eyes or nose, including periorbital cellulitis. Could have uncommon pathogens, for example, after a penetrating injury, exposure to waterborne organisms, or an infection acquired outside the UK. Have spreading infection that is not responding to an oral antibiotic. Have lymphangitis. Cannot take oral antibiotics, exploring locally available options for giving intravenous antibiotics at home or in the community, rather than in hospital, where appropriate. For cellulitis resulting from a wound contaminated with fresh water or seawater, seek specialist advice from a medical microbiologist. Seek specialist advice or consider admission, depending on clinical judgment, if there is continuing or deteriorating systemic signs, with or without deteriorating local signs, after 2 to 3 days of treatment. Symptoms are not improving or are worsening after 14 days of treatment. If a person has recurrent episodes of cellulitis, more than 2 episodes at the same site within 1. Consider routine referral to secondary care for advice on the use of prophylactic Manage acute cellulitis in primary care. For people with class 1 cellulitis, no signs of systemic toxicity and no uncontrolled comorbidities. Prescribe a high-dose oral antibiotic treatment. Before treatment, draw around the extent of the infection with a permanent marker pen for future comparison and to track the spread of infection. This may be difficult in people with lymphedema as the rash is often blotchy. Advise the person to take paracetamol or ibuprofen for pain and fever. Drink adequate fluids. Seek immediate medical advice if antibiotics are not tolerated. The cellulitis becomes worse. There may be an increase in the redness in the first 24 to 48 hours of treatment, possibly due to release of toxins, or if systemic symptoms develop or worsen. Elevate the leg for comfort and to relieve edema where applicable. Avoid the use of compression garments during acute cellulitis. Manage any underlying risk factors for cellulitis. Manage breaks in the skin, for example, due to eczema, tinea pedis, or leg ulcers, which may become a portal of entry for organisms. Manage venous insufficiency. Consider referring people with lymphedema to a specialist clinic. Identify and manage comorbidities, such as diabetes mellitus, that may cause the cellulitis to spread rapidly or delay healing. Advise on preventative measures to reduce the risk of recurrence, including weight management if the person is obese, the use of emollients to prevent dry skin and cracking. Provide patient information on cellulitis. Review the person after 2 to 3 days depending on clinical judgment, or if local symptoms deteriorate, such as redness or swelling beyond the initial presentation, have severe pain, or they develop systemic symptom. If a person has recurrent episodes of cellulitis, more than 2 episodes at the same site within 1 year, consider routine referral to secondary care for advice on the use of prophylactic antibiotics. Oral antibiotics. Oral antimicrobials are as effective as parenteral antimicrobials for the treatment of uncomplicated cellulitis. Before treatment, mark the area of cellulitis if possible. Draw around the extent of the infection with a permanent marker pen for future comparison and to track the spread of infection. This may be difficult in people with lymphedema as the rash is often blotchy. When choosing an antibiotic, take into account the severity of symptoms, the site of infection, for example, near the eyes or nose, the risk of uncommon pathogens, for example, from a penetrating injury after exposure to waterborne organisms, or an infection acquired outside the UK, previous microbiological results from a swab, the person's methicillin-resistant Staphylococcus aureus, MRSA, status if known, for adults with class 1 cellulitis, no signs of systemic toxicity, and no uncontrolled comorbidities. Prescribed flucloxacillin 500,000 milligrams 4 times daily for 5 or 7 days. If this is unsuitable, or the person has a penicillin allergy, prescribe either clarithromycin 500 milligrams twice daily for 5 or 7 days, doxycycline 200 milligrams on the first day, then 100 milligrams once daily, for a total of 5 or 7 days. Erythromycin in pregnancy. 500 milligrams 4 times daily for 5 or 7 days. For adults with infection near the eyes or nose who do not require admission or referral, prescribe comoxiclav 5/125 mg 3 times a day for 7 days. If this is unsuitable, or the person has a penicillin allergy, prescribe clarithromycin 500 milligrams twice daily for 5 or 7 days, with metronidazole 400 milligrams 3 times daily for 7 days. For adults with known lymphedema who develop cellulitis but do not require admission or referral, prescribe flucloxacillin 500 1000 milligrams 4 times daily for 14 days. Amoxicillin 500 milligrams 3 times daily can be an effective alternative, for example, for people who develop adverse effects with flucloxacillin. If the person has a penicillin allergy, prescribe clarithromycin 500 milligrams twice daily for 14 days. Note: skin changes, such as discoloration, may persist for months or longer following severe cellulitis and do not necessarily require ongoing antibiotics. If methicillin-resistant Staphylococcus aureus, MRSA is suspected, consider adding one of vancomycin, teicoplanin, or linezolid to the standard treatments above. Antibiotics for patients with lymphedema should be continued until all signs of acute inflammation have resolved. This may mean taking antibiotics for 1 to 2 months, and the course of antibiotics should be for no less than 14 days from the time a definite clinical response is observed. Review the person after 2 to 3 days, depending on clinical judgment, or if local symptoms deteriorate, such as redness or swelling beyond the initial presentation, have severe pain, or they develop systemic symptom. Other management points: rest and elevate the affected area where possible to reduce swelling and pain. Use of anti-inflammatory medication, non-steroidal anti-inflammatory drugs, and corticosteroids reduces the length of time of recovery and the risk of recurrence. Manage any underlying predisposing conditions, e.g., tinea pedis, skin trauma, ulcer. Clean the wound site. Irrigate. Debride devitalized tissue. Advise use of an emollient to keep the skin well hydrated. Drawing around the margins of infection may help to identify the spread resolution. Assess tetanus risk and status if a puncture wound laceration has occurred. Any patient with crepitus, circumferential cellulitis, or necrotic appearing skin requires rapid surgical intervention. Necrotic skin requires examination of fascial planes to exclude necrotizing fasciitis. Crepitus requires immediate debridement of tissue. Pain disproportionate to the physical examination or severe pain on passive movement of the extremities may indicate necrotizing fasciitis and requires prompt evaluation. Consider the possibility of community-acquired methicillin-resistant Staphylococcus aureus in risk groups and poorly healing infections. Compared with inpatient care, the mean duration of treatment with parenteral antibiotics at home has been shown to be similar, but is almost half the cost. In addition, patient and care satisfaction with home-based care is high. Outpatient parenteral antibiotics should be used where available. Follow up a person on oral antibiotic treatment. Review the person after 2 to 3 days, depending on clinical judgment, or if local symptoms deteriorate, such as redness or swelling beyond the initial presentation, have severe pain, or they develop systemic symptom. If there is continuing or deteriorating systemic signs, with or without deteriorating local signs, after 2 to 3 days of antibiotic treatment, seek specialist advice or consider admission.